Hello, everyone. You are behind the scenes if you're watching on YouTube as we get ready to launch our episode on your SDOH roadmap, integrating social care into healthcare. And you're here with our illustrious group of roundtable experts. We're about to go live in front of our audience in about 10 seconds, so bear with us. All right, everyone. I'm assuming you can hear me okay. We're going to go live. We're all good? Have fun. Greetings, everyone. This is Eric Glazer, and welcome to our live recording of Bright Spots in Healthcare, produced by Shared Purpose Connect. Each episode, we bring you leaders to not only inform all of you, but also unearth bright spots, successes at health plans, hospitals, and other healthcare-related organizations across the country. Our goal is to identify as many bright spots as possible so that you, the listener, can determine if the idea shared on our show could be applied at your organization. We believe this approach of finding a bright spot and cloning it is the most effective strategy to improving healthcare in our lifetime. If you are new to us and you have not yet subscribed to the Bright Spots in Healthcare podcast, I highly encourage you to do so. We've got a bunch of episodes with executives and thought leaders across the industry sharing their ideas tied to that real programs that are really working around this country. So go to wherever you listen to podcasts, type in Bright Spots in Healthcare and press subscribe. And if you really like what you hear, I ask you the favor of giving us a 5-star rating on your podcast app. That really helps us get the word out to other listeners who have not yet discovered the show, but may have a reason to benefit from the show. So here we go. Our topic today is your SDOH roadmap, integrating social care into healthcare. We have an incredible group of experts in front of you. We will not have time to read their bios. Our producer, Sherry Keels, will post those in the chat. And if you're listening on the podcast, they will go in the show notes. This allows us to spend as much time as possible hearing their great stories and bright spots at their organizations. Before we get started, I wanted to greet and welcome our latest partner and sponsor of Bright Spots in Healthcare, and they are none other than Socially Determined, the perfect partner, might I add, for an episode like this. If you've not heard of Socially Determined, they're a physician-founded organization, and they provide social risk intelligence and solutions. They provide health plans, hospitals, and other healthcare organizations, risk analytics, data, and advisory services tied to social determinants of health and social risk among the communities and populations that you all serve and bear risk for. I'll tell you a little bit more about them later on in the show, but for now, if you want to check them out, you could go to sociallydetermined.com. All right, folks, looking forward to this. I want to start and pose the question around resource allocation and how organizations like yours are reallocating resources as it relates to social and healthcare, and how are you investing in social programs and integrating them into your clinical care. So to start, I'm going to bring on Kate Summerfield. She is the president of the Social Determinants of Health Institute at ProMedica and also serves as their vice president of community relations and social investment. If you don't know who ProMedica is, they're a non-for-profit integrated healthcare organization. They've got 11 hospitals across the Northwest Ohio and Southeast Michigan. They've got something like 350 locations around in 26 states around long-term care. And they also have a health plan that has Medicare Advantage, Medicaid, and a marketplace product. And what was about over 10 years ago, they founded their own National Social Determinants of Health Institute. And we are lucky enough to have Kate, who's the president of that group. So Kate, how are organizations like yours reallocating resources and connecting social and health?
Yeah, Eric, and good morning, everyone. Good afternoon, depending on where you are. Thanks so much for the opportunity Obviously, bright spots in healthcare is kind of our go-to in healthcare around all things that are happening. So really honored to be on the panel today. And again, huge thanks to Eric for the invitation. So we really think about this resource allocation in a two-pronged way. First is how we're investing as a nonprofit mission-based organization that has to meet community benefit obligations. And so for a lot of you who either have a nonprofit provider or a payer arm, we're obligated, obviously, from the IRS to actually provide benefit back to community. And the way that we do that is really rooted in place and thinking about how we invest in large areas. And so one program that we launched in 2015 was the ProMedica eBuy Neighborhood Promise. We've been really effective in transforming how we fundraise and do philanthropy work to help reinvest this. And so this is really targeted in specific neighborhoods, thinking about in a comprehensive way, how do we address housing, food insecurity, job creation, and how do we do that in place? So really, again, a robust community engaged process, really relying on residents to drive those decisions. And real quickly, just a couple of stats from the last year. And again, in this neighborhood-based approach, we were able to help 430 individuals actually secure jobs from this neighborhood. Everybody is struggling with workforce and healthcare. So we launched a state-tested nursing assistance program. In Ohio, that's the entry level for nursing. We had 174 individuals actually complete that STNA training. Many of those individuals went on to actually become employed with ProMedica. And then overall, about 5,000 individuals in our neighborhood-based work were connected to jobs. So that's just one example, again, really rooted in place in how we think about investing and allocating resources, getting a win not only for community, but also for the healthcare organization, provider, or payer that you're engaged with. The second area, real quickly, is more around our care delivery model. So we, as ProMedica, are driven by changing our care delivery model. Every patient that comes into our door, whether that's through the insurance arm, through the provider arm, through the payer arm, we fundamentally have transformed the way that we deliver care. If you come into our doors, not only the traditional things, physical symptoms, health symptoms, we're asking food insecurity, housing, transportation across 10 different domains. Again, that's fundamental to how we deliver care. We, in this past year, provided about 160,000 patients, again, across all of our care settings, with social and economic, both identification, but also being connected to resources. And I think one of the powerful things, Eric, is when we understand need, we connect patients, members, and residents on the post-acute side with the right resources, whether it's housing through food prescription programs, whether it's transportation supports. We didn't actually quantify the ROI, and we're seeing reductions in healthcare costs and utilization patterns. And so again, whether it's community-based, really thinking about how we support community in more macro sense, or if it's at the individual level, what we're seeing in the industry is that need identification, deployment of resources, and then tracking of ROI. And again, payers are really starting to fund and support this work. We closed 2021 with 8 different contracts where actually payers across products are funding food, they're funding deployment of community health workers and financial coaches. So, I think there's really a path here. Again, that two-pronged approach has been really helpful for us to think about how we allocate resources and ultimately how we measure impact as well.
And Kate, the annual, how are you funding it? The annual budget is what?
Yeah, great question. So overall, we braid our funding like many folks. So community benefit, we use philanthropy dollars. We closed 2021 with about $20 million in fundraising. We apply for grants, just like everybody. And then there is a system spend. Overall, the bulk of our resources are actually funded through our philanthropy area. We've got a really innovative group that's doing that work. Overall, we're about $3 million in annual system operating budget that goes into social determinants across our entire country. So, given the margins, and given our total budget, we think it's a really good spend for the organization, really driving healthcare long term.
Great. I want to ask the same question. Let's move east a little bit and bring in Dr. Andrea Zeldivar. She is the Director of Complex Care Management and Social Determinants of Health at MetroPlus Health Plan. If you haven't heard of MetroPlus, they are a wholly owned subsidiary of New York City Health and Hospitals, and they are one of the biggest insurers in the New York area, covering over 600,000 New Yorkers. And they also have a 5-star based rating for their Medicaid and Child Health Plus plans. So welcome to the show, Andrea. And how are you doing this? How are you reallocating resources and connecting health and social?
Well, first of all, thank you for the opportunity to share the great work that we're doing at MetroPlus Health. So, Eric, we basically leverage our investment in social determinants of health by having partners, right? So, for example, we partner with our parent or corporation, Health and Hospitals Corporation, to identify housing opportunities for us. We partner with DHS, who lets us know when our members are in shelters, and we have over 4,000 members in shelters, New York City shelters at one time. And then our internal team matches the opportunity with the member and helps the member navigate the system so they can become housed. We've had success, and we've housed over 200 people, members, since the program inception. And if you know New York City real estate market, you know what a feat that is, right? In addition, we have our clinical care managers help us with food insecurity. They identify individuals who may benefit for medically tailored meals, for example, right? And then we partner with God's Love We Deliver, who have nutritionists or dietitians who actually call the member, set up a meal plan for them, and have meals delivered to their home. And lastly, we are a partner with the DOH to purchase health bucks or vouchers that could be redeemed for fresh fruits and vegetables at our local farmers market. So it's all about extending our reach, leveraging our resources, and we understand the value of trusted community partners.
And Andrea, where's your focus as far as the members? Is there a particular market segment? Medicaid? Is it, well, you're all Medicaid, I shouldn't say that, but are we talking about the homeless here? Or are we talking about folks that are just struggling or are dual eligible? Where are you targeting this program?
So we are talking about both. The programs I described touch both our Medicaid and our Medicare members. And we talk about and touch the most vulnerable of New Yorkers. We represent New York, and that's who we actually try to help.
And as far as delivering some of those services like the tailored mails, obviously you're partnering with local organizations to do that?
Yes, and we have state funding for the one program that's related to the Medicaid population, and the Medicare population benefit actually comes from our Medicare benefits. They grow, the health bucks that I just shared from the DOH is one of our benefits under the Medicare line of business.
That's great. I want to shift gears a little bit and talk about sort of strategy and how health plans can think about healthcare and social care a little bit differently. And to do that, I'm going to bring in Dr. Omolara Umadimo, who is the founder and CEO of an organization called Melanin Medicine, and they are a development and funding coaching company, and they help support women of color in medicine to secure capital without incurring debt or diluting equity to build and grow their own healthcare businesses committed to social impact. So Omolara, how should health plans maybe think about it differently, and then maybe even integrate, how community-based organizations play into this overall approach?
Thank you so much, Eric. I often say health begins in communities, not clinics. As a pediatrician, as a global health pediatrician for quite some time, over 18 years, one of the things that I think is going to be needed is a sea change. I think in many spaces, the thought for us was around partnering with communities and being able to still have healthcare centralized in these areas that actually are pretty segregated, right? And so what we're noticing is that a lot of the marginalized communities that we want to impact have to incur a lot of opportunity costs, incur travel time to be able to seek and access healthcare. And so the thought for us, as I'm the CEO and founder of Strong Children Wellness, and I'll explain a little bit about that, was the idea that after working and doing so many community partnerships, we still see cracks. We still see referrals and parents who are who aren't able to have coordinated care. We still see people who have mistrust in the healthcare system and don't believe that they're going to be able to get the care that allows them to be dignified in the clinical encounter. And we still have health deserts, transportation deserts, food deserts, because there hasn't been investment into communities. So from the healthcare side, we decided, my partners, 2 other Black female pediatricians, immigrants, women, decided that we should think about decentralizing healthcare. And this is after multiple rounds of different kinds of community partnerships. And what that looks like is actually creating not just the provider inside of community-based organizations, but a true medical home that allows for us to embed and provide physical health within the social and behavioral health services that these organizations already do and already have the buy-in of the community. It's really important because I think there are 4 levers to this. I think the cultural responsiveness is going to be key. And what we've seen in a lot of interventions is that a lot of the workers who are involved in many of these things in the sea change don't look like the populations they serve. And so thinking about that. Second, I think community centeredness is going to be key. And for our healthcare in particular, not referring to healthcare, but actually how do we embed healthcare in the spaces that we know affect health outcomes? Third, I believe that it's going to be about comprehensiveness. So enhanced navigation is going to be important, as well as collaboration across the Head Start worker, the social worker, the behavioral health. And that's something that we've done to make sure that in our sites that we have in Brooklyn and Queens right now, that the sites and the organizations that we work with, all parties are talking. And then the last is tech enabled. I'm worried that with the social entrepreneurship in healthcare, a lot of the tech advancements have not trickled down into spaces that serve mostly Medicaid. And so what we've tried to do is embed issues like HIPAA compliant text messaging, pre-visit social determinant screening, referral, navigation, and follow-up through your phone, as well as of course, virtual visits. And I think these are the things that payers will need to think about in the organizations that they invest in.
Wow, that was a lot. I'm actually going to repeat some of that back, make sure we got all of that, and maybe for the benefits of our listeners. So I love the quote, health begins in the community, not in clinics. I hope I got that right. I think I did. And then 4 key components to these programs working. One, or I would say it's a combination of benefits and features. One is the cultural responsiveness. 2 would be that it's embedded in the community centeredness, I think is what you called it. 3 is it has to be comprehensive, and we'll get into more about that later on with all of our other guests around navigation and coordination care. And finally, it needs to be tech enabled. Did I catch all that correctly, Amalar?
Yes, you did.
So I have to figure that, we've heard about some interesting ideas, some bright spots that are working, but none of this happens without true knowledge and insights. And that happens, of course, with data. And it's easy to talk about data, but to be able to collect the right data and create action around that data is a whole nother thing. So I'm going to bring in Ashley Perry. She's the Chief Solutions Officer at Socially Determined. And Ashley, how can social risk analytics be utilized to enhance engagement and healthcare outcomes?
Yeah, Eric, great question. Thanks for having us on. So I would say from an analytics perspective, the opportunity is to really use data and analytics to inform resource allocation, investment decisions, and really your overall strategy around understanding SDOH risk for the communities that you care about and individual level social risk factors for the populations that you bear risk for. And so that is what we aspire to do through our partnerships with organizations like ProMedica and Priority Health, is be able to create for those teams a complete picture of, at the community level, what SDOH risk looks like for their full market. And at the member level, to be able to identify, quantify social risk factors for the full population that they're supporting. And that allows you to make more informed decisions around resource allocation and how you effectively work to mitigate that risk, both at the community level through some of the place-based intervention strategies that Kate talked about, as well as at the member level overall. And so that's the opportunity we see taking an analytics first approach to this work.
Can you provide maybe an example of that so that we could kind of picture it in our mind's eye?
Yeah, so for example, to riff on some of the work that Kate was talking about, so as part of the partnership that we've had with ProMedica for several years now, we've been able to generate individual level social risk factor scores for over 1.1 million unique ProMedica patients, Paramount, which is their health plan members, residents within the broader community that they serve. And those scores are domain specific. So we're not just looking at overall risk, but things like financial strain and food insecurity that allow us to empower the ProMedica team, whether that's community care navigators on the provider side or care managers on the plan side, to understand the social needs of members that they're supporting and be proactive about reaching out to those populations to engage them in the available interventions, support programs, et cetera. And we find that's really important because we know that systematically there are great programs out there that exist, but a lot of them miss the subset of the population that could benefit most from those programs because those individuals are not, for example, connected to care today. They may be unlikely to respond to a phone call from an unknown phone number. They may be unlikely to respond to a survey that you might mail to their home, which may or may not be their current address, right? So using analytics allows you to understand the needs for that full member population and be more proactive in reaching out to the subset that could benefit most from the services and supports that you're offering.
I know, so to summarize how I conceptualize that, and I'm going to steal a term I think you said to me in our pre-interview, you're looking at community-wide risk exposure to determine place-based solutions. I mean, that's the overall approach here, the strategy.
So that's part of it. So there's two things. One, at the community level, we look at SDOH risk exposure. So think of that as the assets, infrastructure, resources within a community that impact the risk of those who live in the community.
Yep.
But in addition, we also realize that there are individual person level factors that can actually accelerate or mitigate that risk. And so we also look at person specific social risk factors and want to be able to do both so that we can inform place-based decisions with that community level view and person specific interventions with that individual level view. And we find that it's an and, not an or.
Got it. Great. That's great. I see folks are throwing the questions in the Q&A module. I'll try to sprinkle them in throughout the show. We got a really tight agenda. Some of these I think we're going to cover, by the way, throughout the flow of the conversation, and I'll try to circle back and throw some of these questions out to the panel. Let's bring in Brian McLean, put him on the hot seat. He's been resting too long. He's the Senior Director of Market Intelligence and Digital Products at Priority Health. Those of you who are unfamiliar with Priority Health, are the second largest health plan in Michigan, and they offer an extensive portfolio of health benefits for, of course, employer groups and individuals. They've got Medicare and Medicaid plans that both earned 4.5 and 4 stars, respectively through their HMO and POS and PPO plans. So Brian, let's talk about how Priority Health is understanding data at a community level.
Yes, I think the first thing would be to understand the problem statement, right? What we really wanted to understand is at the community level, where are our members living, and do we have the right resources to match up to the right person? And so when we started looking at that problem, traditionally, you'll use measures like ADI and SVI, and we really found those lacking in a lot of ways, right? They don't get down to the granular level that you really need to get to. And so in our particular case, we said, how can we fill in the gaps around that? We actually partner with Socially Determined in this space as well, to start to understand community risk at the block level. Right? Because that is really where people live. They don't live at a census tract level. They don't live at a zip code level. And if you use broader measures like that, what you're going to do is you're going to miss people. And for example, when we look at some of the zip codes here in West Michigan, if we look at them from a monolithic ADI, SVI perspective, you miss pockets where there is need and there is risk within a larger community that's masked because of averages. So in this particular case, what we did is we said, what gaps do we have? How do we fill those gaps in and create a broader or a more granular perspective of where that risk is? And then on top of it, when you start to understand that layer, you put resources on top of it, right? Where do we have the community partners? Where do we have the needs? where are the grocery stores located? Where are the doctor's office located? And ultimately, you then can layer the member inside that, so that as you've got a care manager reaching out to a member, you're able to identify the need of the person, to where Ashley was going, kind of that joining together of the individual and the community to really connect those the members needing it the most with the right resources. And we look at that both strategically and tactically, right? Do we have the right partners in the communities where our members live from a strategic perspective? And then tactically, how do we connect that person to those right resources for the needs that they have?
And when you have gaps in the data, how do you go about filling those?
Yeah, so we're kind of cursed in healthcare with two big problems: way too much data and not enough data. And I'll say that, and I'll use the example of Z codes, or even if you look at social determinants of health data in an EMR, some of the best EMR collection rates I've seen are at around 70% that they're collecting it on their patients. But then when you look even deeper, that success ratio means that they've collected one indicator. It doesn't mean they've collected all of them. And so what you end up with is a big gap, right? Z codes can't close it. The surveys that we're doing today can't. And so you've got to start to look to other data sources. Part of it is clinical data. And I saw a question inside there earlier about mixing in clinical data. But another piece of it is pulling in traditional socio-demographic data, right? Things like home ownership, car ownership, bankruptcy levels, even, and I'll throw it out there, magazine subscriptions, trends. What have we done? Things like how many addresses you've had in the past 3 or 4 years. And then how do you use that data to supplement the gaps that you have, right? In some cases, for example, we can collect income information on a small subset, but we don't have it on everybody. So how do you fill that gap in so that you can understand economic insecurity for every member, not just a few?
Brilliant. Awesome. Let me do this, folks. I'm going to take a look at the Q&A module in a moment, but I'd like to give you guys a little bit more information around socially determined and what they're all about. They were founded by doctors Ryan Bosch and Trenner Williams, and the idea behind the company was inspired by, in part, Dr. Williams' mother, who is a social worker and had access to so much more data than Trenner had, than family practices had. So Ryan and Trenner created Social Determinants to focus exclusively on social determinants and leveraging social risk intelligence to enable more human interactions at the person level, which we're talking a lot about right now. The company does this by way of their purpose-built analytics platform. They call it SocialScape, and SocialScape generates community-level SDOH risk exposure indices, as well as individual-level social risk factor scores and advanced analytics that empower organizations to understand how SDOH and social risk impacts key business metrics. And that includes suboptimal utilization, total cost of care, quality measure attainment, and health equity, along with member engagement, satisfaction, and retention. The platform, along with all the experts that represent the organization, like Ashley, are trusted by health plans, health systems, life science companies, not-for-profits, and foundations throughout the country. And again, if you want to check out more about them and read more about their story, you could go to sociallydetermined.com. Also, if you want to request a meeting with Ashley, when we send out the feedback form that I'm going to start bothering you about in a little bit, we're going to send that out in about 15 minutes to provide feedback for all of us on how to make the show better and what we could do for the rest of the year as far as episodes and topics. You could also request a meeting with Ashley just to pick her brain, learn a little bit more about what they're doing. It's always a really good opportunity to tap into experts one-on-one. So we'll bring Ashley back into the conversation in a moment, but I want to come back to you, Omolara. I know we talked a little bit about this when you were introducing what we'll call it the reverse integrated care model, but I was wondering if organizations who are listening today were thinking about starting, and I know you mentioned the 4 sort of benefits and components, but is there a roadmap on what they need to be thinking about from an infrastructure standpoint, a resource standpoint, that they could be planning and thinking about if they were going to execute the same way that you described earlier?
Yeah, so there is. It's very robust, but I think the 4 first places that I usually talk about one in any roadmap, but in particular for reverse integrated care, has been valid, visionary, viable, and verifiable. So I'll just talk through those really quickly. The first thing that I think has been really important for us as SCW, as Strong Children Wellness, has been to start our work with not what are we going to do, but a true why. Why are we going to do this? And understanding that we can't go into spaces and assume that we already know why, because we've had some data that we have collected that actually probably has not gotten to the people who are the most hard to reach, right? And so ultimately, in part of that has been working with those communities to start to engage in a way that actually allows for us to truly vet our hypotheses and have conversations. And so getting to the why is going to be the first thing. And if you're thinking about doing this with a community-based organization that has been working in a community for quite some time, not only speaking to the organization, but really getting a touch point of their community members and what's needed. The second thing is, I know a lot of times when we talk about our communities, we talk about vulnerable, we talk about risk. We don't often talk about assets and strengths, and starting to think about not what we are bringing, but what we are building inside of these existing organizations. And so I think about visionary as a piece where we are starting to have those organizations who have felt marginalized and disenfranchised, who are like, nothing's going to come into this community, and having them start to be visionary and thinking about the fact that most times what we'll need to do as people is start to push beyond what we've seen and start to think about, okay, if the healthcare worker was working with, if they could be in here, how would they actually work the best? The third thing is viability and making sure that we think about payers. Now, I deal with pediatrics, and I will be very blunt in saying that I truly worry that payers have not thought and invested in our kids the way they need to. And the ROI is probably the most significant for kids. And so thinking about where is the funding coming from? For us, it's initially come from social impact investment, but how can we push funders to think about family care models? How can we push funders and payers to think more about how do we integrate people across a continuum and not just age-based silos? And the last thing is the verifiability. A lot of times when I talk about reverse integrated care, people think I'm pulling it from the sky. There's actually been a lot of data on reverse integrated care with maybe bringing a specific worker from a health facility into a mental health clinic and seeing a robust amounts of results. However, our goal is to take the little that we've had and expand on that evidence and start to say, where's the incremental visionary pilot that we've seen, and how can we actually supplement that, expand that to address our communities in a different way.
Wow. Okay. Well, whenever there's a list, I feel like that was a pretty comprehensive list. I need to read it back. So why are we doing it? Then you called it assets and strengths. It struck me that really you're looking at inside these CBOs and building on their bright spots, right?
Yes.
Right, come on, and enabling them to be visionary, and then how to integrate best. How to integrate those care providers into their organization to provide the care they need. Viability, which of course is important, and you mentioned we need to be focusing on family care and pediatrics more than we are, and then verifiability. When you mentioned verifiability, you had referenced in some way that there's more validated studies out there than just what you were talking about. If you could provide Sherry that, I mean, I'll put it in the show notes.
Yeah.
Make sure everyone has access to that. I don't want to put you on the spot right now.
Thank you.
Any information that we could provide everyone to inspire them to think about this would be great. Okay, I want to couple of quick questions before I'm going to bring Ashley in, because I really want to talk about, I guess staying on this theme of what could health plans do to be doing things even better. And Ashley, I want to kind of speak to you about SDOH specifically. Before we go there, there's a question from earlier. Have you guys been able to develop analytics around loneliness?
Great question. So actually, this is an exciting recent development for us here at Socially Determined, but earlier this year, we launched a new community level risk score around social connectedness, recognizing that this was always an issue that we knew was impactful in healthcare, but particularly in light of the pandemic and everything that we've seen as a result of that, we were hearing consistently a need for that view of social connectedness for all of the organizations that we're working with. So we just launched that. We think it provides a really important opportunity to think about needs beyond sort of the core SDOH domains that we think about, so food, housing, financial strain, et cetera, but to think about both social connectedness and then importantly also digital literacy and the digital landscape. We recently launched a metric around that as well, recognizing the shift that we've seen post-pandemic towards more telehealth, but also telesupport of social care and being able to recognize the impact that that has on equity and access. So super important things to think about as we put together a more holistic strategy around understanding SDOH needs for communities and social risks for populations.
Great. I'm going to, Omolara, there's a question from Clifford. I'm going to put my words in his question. He wants to know from you, what bright spots can we learn from other countries when it comes to health and closing in between home and community? You don't have to answer that right now. I'm going to come back to you on that. Gives you a chance to kind of prepare for that answer. And I'm gonna stick with Ashley for a moment and go back to sort of some of the planned questions I had for everyone. So be ready for that one. So Ashley, what areas around social determinants and health plans, social determinants, what areas around that are where health plans can maybe improve or do things even better?
Yes, I'll say, Eric, we've seen tremendous progress across the industry in the last couple of years as plans and providers have increasingly realized that this is not anymore a nice to have or sort of an initiative that sits exclusively within the community benefit sphere of their organization, but it really is increasingly a core business strategy that needs to be integrated with the care that they're providing across the enterprise. So really encouraging progress on that front. That said, I think there are a couple of areas where we see lots of opportunity for improvement. One is focusing on actionable data. So understanding not just from like a risk exposure perspective, who is most at risk, but what's actually driving that risk so that you can tune the intervention strategy to the programs and supports that would be most equipped to help meet that need. So for example, when we think about food insecurity, it's not just identifying what subset of your member population might face elevated risk of food insecurity, but also understanding is the primary underlying driver for that risk affordability, for example, or accessibility, or food literacy, or all of the above. But understanding the data with that degree of precision gives you more tools to be able to best mitigate the risk, tee up a solution set that's going to be able to provide the necessary support, and ultimately to move the needle for that individual and the population around that social risk and the impact it has downstream on healthcare utilization, cost, outcomes, equity, et cetera. So that's one big theme. The second I would say is, and we've touched on this a little bit, but ROI and just thinking about measurement in a more advanced way. And I know Brian and I spend a lot of time talking about this, so he's going to have some thoughts. But
because I got a question planned for you on ROI a little bit later.
Yeah. So I won't go too far down that path, but I would just say that there's a lot of opportunity there. We work with organizations that today are investing in a great portfolio of tailored, thoughtful, evidence-based interventions. They have no idea if they're reaching the right people. They have no idea if they're moving the needle around ROI. And so being able to integrate, social risk analytics with clinical and claims data sets, with referral, fulfillment, and programmatic data, and create that full cycle picture of what we're investing in and what return we're getting from it is, I think, the key to making sure that all of this work becomes ultimately scalable and sustainable over time.
Amen. Are there a couple of examples that you could provide just to sort of get our head around this?
Yeah, so one example here from Washington, D.C., we do a lot of work with AmeriHealth Caritas, which is one of the 3 managed Medicaid plans in the District of Columbia. And when we started working with them, they had already launched a really robust portfolio of social care interventions that they were connecting their members to, but really didn't know if they were working or not. And so we had the ability to use our SocialScape platform to do an analysis to look at the impact across those programs, across a consistent set of metrics. So things like, were they actually reducing low acuity ED utilization? Or were they preventing 30-day all-cause readmissions? And being able to create that consistent view, right, of the impact of those types of programs across a consistent set of measures, tees up for that team an opportunity to think more strategically and in a data-driven way about the investments they make in that portfolio of interventions going forward. So, which programs do they scale? Which ones do they potentially refine? And which ones, candidly, do they consider sunsetting because they're not generating the return that they would like to see as a plan, and they're not benefiting the members in a way that the plan would like to drive? And so that ability to sort of think more comprehensively about how we're quantifying ROI and being able to do that in a way that scales across your entire portfolio of social care programs and partnerships is really important when we think about those long-term investments and driving scalability over time.
Great. I'd love to double click on that, learn more about the results. I think your team had sent me a case study you guys wrote up on that. They may have some more details on this.
Yep, that's right.
Why don't we do this? Sherry, if we could put up a poll, anyone that wants me to send you this copy of the AmeriHealth kind of just overview and case study that has even some more details than just Ashley just shared, I'll send that to you. And in fact, Kate, I have a question for you, and I know you sent me, or your team sent me, your social impact study from last year. So I'll send that with everyone too. So if you want the AmeriHealth case study and the ProMedica social impact report, sort of gifts for just participating, click on yes on the poll. If you're listening to the podcast, we're not gonna exclude you. Just shoot an email out to feedback@sharedpurposeconnect.com and request the report and the case study, and we will send that out to you via email. So you can get that really easily. All right, awesome. So let's talk about, Kate, how everyone listening could think about an enhanced delivery program, and how can they blueprint an alternative or enhanced delivery program that connects social into healthcare. Could you provide some guidance for us there, like a roadmap for us?
Yeah, Eric. So we've been at this almost 10 or going on 11 years. So we've gotten a lot of things right and a lot of things wrong. So we want to be able to share as much as we can. Here's the lessons learned. Here's the things to avoid. So just to give you a sense on how, and maybe a couple of key points, depending on where you are in the process. I would say the first part is really engagement. And there was a lot of discussion in the chat around how are we engaging community, those that we're trying to serve, how are we engaging them in the process? And so from just a really intentionality, being community driven, starting with that engagement and starting to actually have discussions, whether you're in a clinic setting with an FQHC, when you're in a larger healthcare system, really starting to engage with those in community and getting feedback, both your patients and your non-patients. Again, being really community driven is core in terms of buy-in, feedback, and ultimately making sure that we're developing the right solutions. I'd say second, we've got to also think about engagement of our clinical teams. If you think about from a patient perspective, we've got 6 to 8 minutes from the time that someone is in our care settings. And so engagement of our clinical teams, our physicians, our nursing, our operations teams, really critical from the first step. We were able to identify early on a physician champion and a nursing lead champion that was very helpful. As a non-clinician, a non-doctor, I can go and talk to all of our doctor colleagues till I'm blue in the face, but all of a sudden a peer-to-peer starts to talk about the importance of social determinants, how we're going to do this across the organization, and how this fits in within our mission. It really flips the conversation. So I would say identify both a physician champion within your organization and a nursing champion, and ideally some type of operational administrative champion as well.
Three champions.
3 champions. Yep. So that's
a Malara, a nurse, and an operations person.
We've got the dream team here, right? Second is really thinking about efficiency. So we started very small in one practice with one provider that was very engaged. And we were very intentional to making sure that social determinants was not this add-on extra thing that we were asking our team to do, but that we designed it from the front end to really be embedded in the EMR. So whether your EMR is one of the big ones, whether you're a small one, and across providers and payers, really thinking about how you embed social and economic screenings and solutions and that closed loop into the EMRs. They're getting more and more effective and efficient. So whether you have a care management platform, case management platform, you've got one of the big EMRs, there's really a lot of technology and innovation that's happening. So be very intentional about how this gets embedded. we started again in one small practice. And over time, as we grew, we were really intentional to engage with our IT colleagues. If you don't have an IT analytics person on your team, go out and find your CIO, MIO, your CIO, find someone. You're going to need your IT team to be involved in this. We made sure that it was seamless, no-touch workflows where we could. So about 50% of our screens to date are actually happening before a patient comes into our care setting, and they're done in the pre-setting assessment within the EMR, right? So that's really helping to take time away. There's certainly a population that don't have access to computers or digital, where we're still doing that engagement in the front end during the office visit or the acute care stay. But as much as we can try to push that, use technology as much as you can. The last two I would just throw out real quick is around impact. Ashley talked a lot about challenging and thinking about ROI. We've been able to show, based on a lot of data and a lot of hard work, that we can actually quantify our impact. Financial coaching as an example, we're seeing individuals who are receiving financial coaching, we're doing that free tax credit, helping with employment and jobs, building credit over time. On average, about a $350 monthly increase in income that's resulting in utilization change. So about a $9,000 reduction in cost for those that are engaging in our financial coaching programs. Just again, one example, lots of great work around the country happening. And then the last thing I would say is just around innovation. There's a lot of work happening in this field. There's a lot of work that we're doing. I think we have 35 different solutions and programs running to date. There's things that are not working. And so being really clear and thoughtful around measuring that and understanding there's going to be things that fail and being okay with that failure and being willing to innovate. So we went during COVID all virtual. So our financial coaching that I mentioned, seeing great ROI, we actually were able to transition all of those in-person services into virtual. We provided folks that did not either have digital access or computers. We were actually able to partner with local partners in the community and provide that access, but really thinking about innovation as that final. So engagement, clinicians, community engagement, how are you effective, really building this into the EMR, measuring impact, and then finally around innovation and being okay to fail and fail fast in this work.
Wow, and you did my job and repeated back the list. Well done. Before I move on to the next question, next week, folks, we're going to stay on this genre around SDOH. We're going to get into a more focused, we're going to double click on engagement and reaching the hard to reach. And the title of next week's episode is creating a more human holistic approach to SDOH and reaching the unreachable. We're going to have a couple of national payers on. So if you want to join that live recording next week, 12 o'clock Thursday, 12 o'clock East Coast time, Sherry will put up a poll. We could pre-register you, so you don't have to click and log in. And those of you listening to the podcast, simply go to sharedpurposeconnect.com, click on register for the event, and for free, you could quickly register and attend live next week. I'm going to come back to Andrea Zalvadar. Andrea, how are you actually executing on the clinical part of this? Like, I know it's easy. It's easy to say, hey, we're going to integrate health and social care, but how do you truly think about the clinical workflow and making sure that you're planning appropriately so the people providing the care can easily do it? And maybe share an example of how you're doing this at MetroPlus.
So I very much appreciate and love this question, right? Because we know the data, social determinants of health makes sense. Everybody's like, of course, housing people, getting food makes perfect sense. But how do you translate it in the real world, right? And get the services to the individuals that Omolara was referring to. So anybody who's been in healthcare for a while knows that you try not to reinvent the wheel, right? You go with the existing workflow in order to get buy-in from your staff and individuals in general. So we spend a lot of time looking at the actual workflow that currently exists in our outreach to members, right? We spend time looking at screening tools, and there are many screening tools. The literature is full of them. We can have 20 questions or you can have 2 questions. We chose a few questions only because we realized that our care managers needed to ask many questions, and social determinants of health couldn't be a whole other 20 question. We also realize that the gold standard for addressing social determinants of health needs is at the time that the person expresses the need, that we can match them and give them the resource, right? It doesn't work to say, so-and-so, whatever department will call you in a week. It doesn't really help sometimes to call this number and get connected. The best gold standard is to give them the resources at the time that they're there, they have the express need. So we incorporate the use of NowPow or Unite Us, which is a referral resource platform that gives us our care managers information in real time on a community level, right? We also, I think Kate mentioned this as well, that you have to have a documentation system, a system where you actually can look and audit that the process is working. So we have that. We do monthly audits on our staff. And most importantly, you need to share that information with the staff themselves and get their input and say, how can we do this better? What were the obstacles? What were the barriers? So that actual translating it into an existing workflow is something that we do and spend a lot of time on, because you don't want to waste time, right? You don't want to reinvent something that's already there. You just want to make it as easy and flawless and support the actual staff that's doing the work.
That's great. So if I could, the tool is the key, one of the key things, the documentation, the ongoing tracking, you call them audits?
We call them audits, but it's just really evaluating whether the workflows that you have put in place are working, right? And tweaking them along the way before you get too far into the process, right?
And then the feedback, right? And being able to
get the input from the people who are actually doing the work, right? And see how you can facilitate their activities.
Great. Let's now talk about impact. We teased out the ROI question. I know Ashley had touched upon it. So Brian, I'm going to bring you back on. And Ashley, you could jump on top afterwards, and just how everyone should be thinking about ROI and maybe thinking about ROI a little bit differently.
Yeah, so first of all, I think our traditional ROI measures are around investment, right? And they're 3 to 5 year horizons. They're for avoided cost. I'd say at that point, they become a lagging indicator in a lot of ways. Did we get something back 3 to 5 years later for the investment we put in? I think we need to shift more to leading measures in this space. How can we understand those things that are occurring today that are going to contribute to that long-term success in avoided care? So we look at things like retention rates, for example, right? The longer we can keep a member, the more likely we are to help those members. We look at member satisfaction, right? Are people finding value in what we're sharing with them? We also look at engagement in other programs. We believe when we look at the data, once we engage a person in one program, we can engage them in more programs and improve their health across the board. We look at things like closures of gaps. I think both Andrea and Kate mentioned earlier, it's that real time. How do I get a person to a resource right away? That's the type of measures that you need to have there on your ongoing scorecard, so that you're saying, are you building the right pieces to ultimately get that 3 to 5 year calculation? So you can start to shift course now and do things a little bit differently.
Anything to add to that, Ashley?
Yeah, so I would just say that the other two pieces that we've seen be really important is to think about the time horizon here. So not only what are we aspiring to measure, but how quickly do we think we can actually move that metric? And then how quickly are we going to see signal of that movement in whatever data source we're using to quantify that ROI. So just being really candid and transparent when we start these interventions and partnerships around what that looks like, so that all of the partners at the table understand what we're trying to do and how quickly we think we can do it, and that we're all invested in staying in the partnership and in the program throughout that time period. The other part I think about it is Brian and his team have been so thoughtful about thinking about both like more proximal measures of success that give us confidence that directionally we're moving in the right direction, and then it gives us the ability to sort of have that longer term view around ROI ultimately. And so just thinking about quality measures, other measures that we can pull forward, right, to be able to use as proximal measures of success. And then that buys us some time to have that longer term view to get to things like bigger picture changes in total cost of care, et cetera. So you want to have a multi-pronged strategy around ROI, and you want to be really thoughtful about that at the outset, just so that everybody's starting this work with the same kind of view of what it's going to take to do it and how long it's going to take to get us there.
Yeah, I think it was brought up in the chat as well that using midterm measures like avoidable hospitalization, gap in care closures, other clinical measures that are ultimately leading to those avoided costs because of the progression of chronic disease and other things, make it multi-layered, right? What can we do in 6 months, 12 months, 2 years, and 5 to get us to that long-term success point?
Spot on.
Eric, I just wanted to add into that really quickly is the fact that I think as we move and as we expand, especially thinking about social determinants, even we have to think a lot more about health outcomes as a outcome from what happens socially, socioeconomically. And so when we think about ROIs, we're always head first on hospitalizations, ER visits, what's happening for our kids in terms of school graduation rates, what's happening in terms of the other issues that are really important and tell us over time that this is going to be an adult who potentially will likely be a lot more healthy. Adverse childhood experiences, which we know have a quadruple effect on negative health outcomes. So what do those things that we haven't ordinarily thought about and aren't on the HEDIS list are things that we need to start capturing and looking at?
So Omalar, I'm gonna keep you on the spot, and Andrea, I'm actually gonna try to use, because I know we only have 5 minutes left, so I'm gonna ask 2 questions at the same time. Andrea, there's a very tactical question in the Q&A module that I don't know if you could type out and then share with everyone, because I think it's a good question to get answered. I just don't know how it may not be relevant to everyone in the audience. And then Omalara, I'd love to be able to go back to that question around bright spots in other countries. Is there anywhere that you've looked that our audience members could be tapping into via Google or wherever to learn about what's going on in other countries around social determinants and home and community that maybe they're doing in a way that would enhance what we're doing here?
Yeah, so all of my work that I've done over the past 18 years has been globally informed. For the first decade of my life, I was working not in the US, and because of the lack of resources, the innovation that had to happen, when I would come back and people would look at me and say, what we can't, what are you talking about? Like, they're doing it over here. Some of those things, when I worked in Cuba, consultorios, and the idea of having the doctor nurse actually for every block, right? And having that unit where people were actually coming directly, not just for a health worker, but their true primary care. And how do we decentralize healthcare, which was an instance for that. Lady health workers in Pakistan was a huge emphasis for the community health worker movement here, right? And seeing infant mortality rates go down. I think in Malawi, seeing the task shifting that happened during the AIDS epidemic of now we saw that we needed an expanded workforce, and how do we get one that doesn't have to rely on physicians, on nurses, but still have the ability to provide quality primary care. In general, the biggest thing that's most important is knowing that when you look at things like infant mortality rate in other countries, OECD countries, right, high economic countries, all of them that are under 3 or 4% have at least 20 to 30% of social spending of their GDP, 20 to 30% of our GDP on social spending. And so for anything, we're going to have to get to that for us to really move the needle overall. And that's something that we can take from the world globally.
Gold. Just like I brought you in for as a paid Bright Spots employee. So I'm going to throw this question out. This is sort of spontaneous here, so I understand we may not be able to answer it. But Aaron asks, and Ashley, I'll have you start. And my guess is, it's probably going to be a jump after that. Everyone will probably be able to answer it. How can we pre-populate SDOH data for a new patient for provider pulled, whether it's pulled from credit history, block data, without being creepy or offensive for the patient?
Yeah, so I would say one of the advantages, right, of using social risk analytics is it allows you to understand the social risk exposure of an individual, newly assigned member, et cetera, without necessarily having any claims history on them, right? That's something that we've actually been working with Brian and team on a lot. They get newly assigned members, we can generate risk scores for them across multiple domains before they have any other interaction with them, which allows them to have a more meaningful interaction with that member early in that relationship, right? That is great. On the creepy front, I will say, just in the interest of time, so there's no shortage of data out there available about all of us. So the key is to harness that data and use the power of that data for good by providing a more complete view of the needs of the populations that we all serve and using that to better support them. There are plenty of people that are out there using that data for other purposes. That's not the business that any of us are in. But I think there is a real opportunity to use that data that's available through a variety of commercial and proprietary data sources to provide more holistic, complete socio-clinical care that really does move the needle around addressing, utilization cost and health equity, but also provides a pathway to more scalable, sustainable investments in these kinds of interventions. I've seen in the chat, there've been a lot of questions about how we make the funding sustainable. The way that we do that is we prove that it generates a return and that it's not just the right thing to do for these communities, but it's the right thing to do for businesses. And that's where we get to real sustainable investment in this work.
Eric, I'd add, we also take, oh, sorry.
I may just
Kate.
add real briefly. I think also as healthcare providers, we have to be focused on trust building and understand the historical distrust that healthcare has created, especially in our Black and Brown communities that have been historically disinvested in. And so I think transparency, relationship building, trust building through the process is incredibly important. Healthcare has a long way to go in that space. We're still all learning. And so we got to continue to push ourselves to make sure that we're really rooted in community.
I think to further that, it's the education of our team members on how to use this data in a constructive way. So when we get it, we talk with our care managers and others about the need to use it for probing, for asking questions, for understanding, not to jump in and start to say, I see this, right? It's a way to help to get an initial place to start from a Q&A perspective.
I think it's a good bow on this as we're at the top of the hour. I want to thank all of you on my illustrious roundtable. You were terrific, everything. As advertised and maybe above and beyond. I want to thank all of our listeners for joining. We know here that it's a privilege to gain your attention for an hour every episode, and we view that as an important responsibility to provide you value every time you listen, every time you log in. So our perspective has always been, this is your podcast and we serve all of you. So to that end, remember to fill out that feedback form that has been emailed to you if you've attended live. And for those of you listening on the podcast, feel free to send your feedback out to the team at feedback@sharedpurposeconnect.com. I promise you, I look at every single one of those emails. That's not some sort of like never looked at mailbox. So with that, thank you all for joining and listening to your Bright Spots in Healthcare.